Welcome to this third edition of our special series on the Ebola crisis. The Ebola outbreak continues to accelerate in West Africa and has killed 1,552 people so far. The number of cases now stand at 3,069, with 40% occurring in the past 3 weeks. The World Health Organization has warned the number of Ebola cases could rise to 20,000, as doctors in Liberia say the deadly virus is now spreading so rapidly they can no longer deal with the crisis. Now, that crisis remains centered in Liberia, Guinea and Sierra Leone. Nigeria says it has the disease under control. This week, the DRC confirmed 2 Ebola cases, but says they were unrelated to the epidemic currently ravaging West Africa. Now, for many outside his circles, the name Peter Pio may not ring a bell. Professor Peter Pio is the researcher who, in 1976 in Zaire, in what is today the Democratic Republic of Congo, co-discovered the Ebola virus. He describes the latest outbreak in West Africa as unprecedented. Professor Peter Pio was born in Belgium in 1949 and is a former Under-Secretary General of the United Nations. He has also served as Executive Director of the UN Specialized Agency, UNAIDS. Professor Pio is currently the Director of the London School of Hygiene and Tropical Medicine and is a Professor at the Imperial College in London. His most notable awards are the Vlerick Award and the Flanders America Award. Now, in an exclusive interview with CCTV's James Chow, Professor Pio retraces the origins of the virus, makes wide-ranging suggestions on how to tackle it, and warns that there must be no time to lose in the event of an outbreak.
Over 1,000 dead, more than 2,000 infected, a fatality rate of up to 90%, quarantines, travel bans, limited treatments. Peter Piot, what is it about this Ebola outbreak that worries you most?
This Ebola outbreak is the largest and the longest that we've ever known. It came a bit as a surprise when in '76 we investigated with our team the first known Ebola outbreak. It was very localized, and all outbreaks since then have been, sometimes serious with a few hundred people who died, but always local. This, for the first time in history, is affecting West Africa. Secondly, it's affecting 3 different countries in a major way: Liberia, Sierra Leone and Guinea, and then with Nigeria in a big way. Thirdly, for the first time ever, major cities, the capitals of these countries have been affected. And also something we've never seen is the often hostile, if sometimes violent, reaction against the control measures. So this is unprecedented.
Not only national health systems are struggling, the international charity Médecins Sans Frontières says it can only do what it can do. What do you think is likely to happen next if more cracks appear in the global response?
What we need now is a major concerted effort of the international community to support the local authorities, the local governments, the local NGOs, because the solution can only come from within. And that solution is not so easy. In theory, in order to control an outbreak like Ebola, hemorrhagic fever, it's fairly straightforward. You isolate someone who is ill, the contacts of that person who may become infected. Sometimes you put in quarantine people who are healthy, and you provide some supportive treatment. But in practice, this is very, very complicated. What we're witnessing in West Africa is a perfect storm. We do have such an unprecedented, vast epidemic of Ebola hemorrhagic fever because these countries are coming out of decades of civil war, Liberia and Sierra Leone, resulting in dysfunctional health systems, poor health services and public services, a lack of trust in authorities. There are also traditional beliefs in causation of disease, so that people think often it's more to do with witchcraft than with a virus. And also, there has been very slow leadership. Fortunately, all this is changing now in the sense that the countries have declared the epidemic as a public health emergency following a decision by the World Health Organization, and the international support is now developing, but it's still not at the level that it's needed.
You've made a personal call for infected patients to be given immediate access to experimental drugs, none of which have been fully approved yet. Do you think this will expose them to higher risk?
Well, first of all, when you think of a disease that has up to 90% fatality rate, compassionate use of experimental drugs is absolutely justified ethically, and that was confirmed by the World Health Organization. But secondly, we need to make sure that this is the last outbreak of Ebola where all we have is isolation, quarantine, and some supportive care. We need to make sure that we have stockpiles of effective therapies, of vaccines, when the next outbreak will come, because there will be a next outbreak. The virus is hiding somewhere in nature, some animal, probably some fruit-eating bat. And Central Africa up to now has been affected multiple times. This is the 25th known outbreak, and there will probably be more in West Africa. The populations there are growing, people are more mobile and are more in contact with the forest and wherever the virus is hiding.
I am declaring the current outbreak of Ebola virus disease a public health emergency of international concern. The committee's decision was unanimous. Its advice to me acknowledges the serious and unusual nature of the outbreak and the potential for further international spread.
Much has been made in the media about the 2 American doctors who were given experimental drugs, but how much of their recovery was to do with the drugs versus the first-class US medical hospitals they were in?
2 American doctors received a drug called ZMapp. These are antibodies that are trying to neutralize, to eliminate the Ebola virus in the blood and so on. And we can't rely in medicine on the results of 1 or 2 patients, because we also had a Spanish priest who got the same drugs and a Liberian doctor, and both of them died. But there's some good news that is coming from experimental treatment in macaques, a kind of monkey. And out of 18 monkeys that received this drug, even up to 5 days after being infected, none of them really died. And that's just compared with 100% fatality in the control group. So we have some hope that there are treatments. And if we've learned one thing from AIDS, it is that just concentrating on prevention measures without dealing with those who are affected and who are dying, that doesn't work, and that doesn't inspire trust. So we need these drugs dramatically. They may not make a huge difference for this epidemic, because we still have to go through some rigorous testing, clinical trials, but let's make sure that for the next time they are available in Africa.
This is the question that everyone will have, especially for that next outbreak. How far off are we from a vaccine for Ebola that's accessible to all?
We'll have to test them and evaluate them when there's the next epidemic, because the only way to find out whether a vaccine works is to test it in humans, and for that we'll need the next epidemic and be ready. But the good news is that thanks to this epidemic of unprecedented proportions in West Africa, there is a renewed interest in funding research in terms of treatment and of vaccines. My worry was always that once the crisis is over, that people think, okay, we go back to normal, they forget about it. This is not a huge health problem in most parts of the world, so there's no market incentive. So there's a need for public funders and charities to come in.
Peter Piot, let's move now this discussion to the historical part of Ebola. What took you to Zaire in 1976, and how did you first come to isolate the Ebola virus?
In 1976, I was 27 years old, and I was in training for clinical microbiology just after my medical studies. And I was working at the Institute of Tropical Medicine in the laboratory. And one day in September 76, we received a blue shiny Chinese thermos straight from Kinshasa, the capital of what was then called Zaire, now the Democratic Republic of Congo. And that thermos contained 2 vials. One was broken and was kind of swimming in a bit of ice cubes and water, the thermos. The other was intact. And the vials contained blood from a Belgian nun who had died in Zaire with a diagnosis of yellow fever, ? And our laboratory was certified to isolate yellow fever. And so we did the normal virological investigations. We were cautious, but we didn't have the maximal protection that's really required. And out of all these tests, meaning you put the sample on cell lines, you inject it in mice and baby mice and guinea pigs and so on. This is the old-fashioned virology. Today it's far more sophisticated with molecular techniques. Out of that came a virus. And when we looked at it under the electron microscope, because a normal microscope is not strong enough, powerful enough to see viruses. That's good for bacteria, like the one that causes tuberculosis. But for a virus, you need an electron microscope, which magnifies 100,000 times. And then what we saw was a worm-like structure. And we were really puzzled. We hadn't expected that. And it looked like what the only other known virus in these days that looked like it was Marburg virus. Marburg is a town in Germany that had experienced an outbreak of a very deadly viral fever. And that killed polio workers in a vaccine plant. And so we thought this may be Marburg, and that created a bit of panic because we were really not equipped for it. So WHO instructed us to stop all the work in the laboratory, and we sent the samples, the isolate, to the US, to the Centers for Disease Control, where they confirmed that this indeed was of the Marburg family, but was different. And so that's how we isolated the virus. And it was pure accident, and we did our work.
Far from just the laboratory and the science of it all, you yourself went to what was in Zaire. You talk about in your book, No Time to Lose, the victims of Yumbuku and them having bloodshot eyes, severe abdominal pains, also severe bleeding. How traumatic was that for you, not only as a physician, but as a 27-year-old?
Yeah, I went straight into the epidemic center, a place called Yambuku, which is in the northern part of Zaire, of Congo, about 120 kilometers north of the Congo River, where it comes at its most northern point. And it's a very poor area. And we saw, when we arrived, people who were sitting outside their huts, their houses, or inside, and many had, bleeding that was not stoppable, blood coming out of their mouth, of their ears, nose, and were lethargic. Were with this look in their eyes that you could see they knew they were going to die. It's something I've seen also later when I saw the first patients with AIDS in Africa. That was like about 6 years later. And it was shocking. It was my first time in Africa. So I had to absorb a lot of things. A new continent I had always wanted to visit. I was very excited as an emerging microbiologist. Discovering a new virus is kind of one of the ultimate dreams that you can have. But then also being confronted with the devastation, and particularly with Ebola, is affecting entire villages and families. So it was a very, very sad situation that affected me deeply.
You say in your book, I was so frightened that I could barely admit to myself what I was risking at a certain point you showed symptoms of Ebola, didn't turn out to be that yourself, but you were exposed every day to incredible life-threatening risks. When you think back on that time, what do you carry from that period?
I got more scared afterwards than at the moment itself, because let's not forget, today we know that this kind of Ebola virus infection with the Zaire strain, that the case fatality rate, as we say, is well, up to 90%. We didn't know that. We had no clue how it was transmitted. That, for me, was the scariest part. Are these mosquitoes? Is it food? Is it water? Is it, sex? We had no clue. All the ways that a virus can be transmitted. So that was, together with stopping the epidemic, the spread of the virus, our first mission was to find out how is this virus transmitted. And how did we find out? You ask actually 3 very simple questions. And that is time, place, and person. You define this epidemic. You see, when did it start? How is it evolving? Is it still going upwards, as is the case now in West Africa? The number of cases continues to increase. Or is it going down? And from the shape of that curve, you can learn something.
Peter Peel, we're going to go to a quick break, and we'll return to talk about your contribution to Ebola. The current outbreak is said to have a Zaire lineage. Are there similarities with 1976 in terms of the pathophysiology? And where particularly do you offer personal, unique insight now?
First of all, it's the same virus with very high fatality rate. But what we've seen is that thanks to efforts from groups like Médecins Sans Frontières, that mortality has been decreased to 50% if you get good supportive care. Now, 50% death rate is still enormous, but it's better than 90%. Secondly, what's very similar is that healthcare workers are the front line. Over 140 doctors and nurses have died from Ebola in West Africa today, and hundreds more have been infected. And so that has also a major impact on the capacity to deal with an epidemic. Thirdly, what's very similar is these outbreaks around funerals. In every society, there are rituals to deal with a corpse, with a dead person. In the West, it's often a professional who cleans the body, washes it, and so on. Both in what I've seen in Zaire and in West Africa, the whole family is involved in it, touches the body, and that's very, very risky because these bodies are highly infectious, full of virus. And that is a practice that, is fatal now in times of epidemics and has to change.
You won the Noguchi Prize for Medical Research, and at the ceremony in Tokyo last year, presidents and prime ministers from across Africa came to congratulate you. My question, though, is this. Do you congratulate them on their political leadership on Ebola?
Well, I think that the leadership on Ebola has been quite slow, both locally in the countries affected and also internationally. The first alert was given in March when officially it was confirmed that Ebola was hitting Guinea. It's only at the beginning of August that a state of emergency, of public emergency, was declared. On the other hand, Nigeria has acted in a very responsible and prompt way when this man from Liberia came to Lagos and actually infected a number of healthcare workers. And we're seeing also that there's this outbreak now in Congo, in DRC, where immediately the Minister of Health is going. So it's a mixed bag. But I think, in all fairness, in West Africa, this is the first time ever it happened, and probably nobody could imagine that it would be that bad.
Let's talk about the future, the immediate next steps even. Health workers in Sierra Leone have described the environment, the atmosphere, as initially traumatic, something that you identify with, but now getting a little bit routine. You've spoken in the past about your great concern over the complacency linked to HIV and AIDS. Do you worry that there will be that same complacency about Ebola, that it will just be dissolved into another news story, another crisis that we don't act upon?
Well, I think that for the countries themselves, the populations, Ebola will not become normalized in a sense, because it's so dramatic. It kills you within a week or two after being exposed. It is also a horrible death. There is a lot of fear and panic. And this is unlike HIV, where you have a silent epidemic and where we're seeing more and more complacency. With Ebola, I'm not so concerned. I think the key now is to overcome the fear of the virus and really put in place all possible measures to contain this epidemic and to care for the people who are affected by it. And that will require massive international assistance in addition to, of course, the work in the communities themselves.
Naho lemiwana na dendulani ando nansengu ha nanja konendani nandindini because me ana chomda peya voma naho onona kiwa ndio na telenda kiondo.
But what Ebola and AIDS share in their epidemics is that fear. Have you seen fear of rejection, fear of dying, fear of turning in a positive result prevent people from seeking help when they could still seek help?
Well, that is what has been happening in West Africa, and that is that some people say Ebola doesn't exist, and that's denial is a human first reaction in the face of a catastrophe. That you say, no, it's not true, it can't be true. So that has been it. Secondly, there are stories of families who have even taken away their relatives out of the hospital, and the relatives had Ebola, were in isolation, and these patients then have infected other family members. So this fear is one of the big obstacles to deal with the epidemic.
4 decades ago, your professors in Belgium warned you against pursuing a career in infectious diseases. And how wrong were they? Because they said that good hygiene, antibiotics, vaccines would render these irrelevant. You proved them wrong. What do you predict? What will be the next Ebola?
Yes, when I was last year in medical school, my professor said no future in infectious diseases. I think it's difficult to predict the future, but one thing we know for sure is that there will always be new viruses coming up, emerging, or mutate. Take influenza, the flu. We know that now and then there is a change in the makeup, in the coat of that virus, that then can create a big epidemic, even a worldwide epidemic, because we are not protected, we are not immune against the new virus. So that is going to happen. A worldwide flu epidemic will come. We've seen SARS coming up. We've seen now in the Middle East so-called MERS virus. We will see new epidemics of Ebola virus. And what they have in common is that most of them come from animals. The flu comes from birds, from poultry, or from pigs. HIV comes from chimpanzees originally, Ebola, maybe bats. And that will continue also as the population grows, that we have more contact with animals. This is something that will happen. And then we have another problem that is man-made, and that is antimicrobial resistance. Because of misuse and bad use and overuse of antibiotics in animals and in people, we are now confronted with untreatable infections, like untreatable tuberculosis. And that's also a challenge for the future. So there is a future in working on infectious diseases. We must protect the world from it.
There's talk now of perhaps a travel ban. There's been cancelled international flights. There have been quarantines around entire towns and villages. Do you worry that this current outbreak of Ebola will leave a legacy where the people of West Africa are isolated by this disease, people who are already detached by poverty, by hunger, by violence?
The impact of this epidemic will go way beyond the number of people who died and the damage to families and so on, because there will be orphans left. There's economic damage. We need to restore the trust and we have to rebuild the health services. But I think that the cancelling air travel, for example, that doesn't make sense to me in terms of trying to control the epidemic, and makes things worse. Because how to provide international assistance if you can't get there, isolating the countries is not going to control this epidemic. In some cases, quarantine of parts of a country can be justified as long as we make sure that economic activity can continue as well as it can, that people have food and that basic services are provided. Otherwise, the quarantine won't work, and then, it will make things worse.
My last question to you is this. Your studies of diseases has led you, in your words, to a path of self-discovery. As you head this weekend back to Africa, is there that same opportunity for Ebola?
Investigating the first known Ebola outbreak in '76 was not only a journey of discovery of a new virus, a new disease, but was also a journey of self-discovery. And I discovered Africa. I, paradoxically, amid all this tragedy, I developed a deep love for Africa, the way that people in very difficult circumstances managed to control an epidemic, managed to survive, have creativity, and have a very strong, vital energy and a wish to live. So that's something that, for me, I owe to Africa and to many African friends. And I've been going back so many times. And so when my 65th birthday was approaching, I went back to Congo. I was probably one of the few tourists there, because I wanted to celebrate them and thank the people who have meant so much to me in my personal and professional development.
Peter Piot, thank you very much.